Imaging, again, CT is going to be the workhorse. About half of these patients with AVMs are going to present as a hemorrhage. A smaller percent are going to present as seizure or some sort of focal neurologic deficit. And then obviously there are the kind of incidental findings. But what you're going to want to see on a CT scan, you can see hemorrhage, obviously. You can also see vascular calcifications, these kind of curvilinear, kind of chunky calcifications. Almost look like, they're related to like a venous thrombosis, so kind of thing. Our MR is, an unbelievably powerful instrument when looking for AVMs. I mentioned the GRE and the SWI sequences. Hemorrhage, we have a nice paper out of our group talking about the importance of identifying microhemorrhage, because we feel that even in the setting of microhemorrhage, meaning within the AVM, it does actually manifest clinically. Those patients still carry the same higher rate of bleeding within that first year after the hemorrhage than any other year of their life. ASL can be helpful in terms of its sensitivity to find small AV shunts. Bulb imaging is something we use for functional magnetic resonance, and so this is for patients who have AVMs that are near or adjacent to or even within eloquent tissue or classically eloquent tissue. And then obviously MRA and CT are essential in terms of understanding of AVMs. DSA obviously remains the gold standard of surgical grading. But remember that a lot of AVMs will have blood supply to them that comes from multiple different distributions. So you can have an AVM that receives both posterior cerebral as well as lower anterior cerebral supply. So a CT or an MRA can help put all those in one picture as opposed to a catheter angiogram, which can only look at those kind of piecemeal. In terms of scales, the Spetzler-Martin scale was published in 1986, and really is a wonderfully informative scale. It very simply enumerates the size of the AVM, its presence or absence of deep venous drainage, and its relative location, whether it's in eloquent or non-eloquent brain. And what that does is it speaks to the surgical risk, the open surgical risk of treatment. It does not speak to the natural history of an AVM. It does not speak to the treatment risk for Hemorrhage therapy or to endovascular therapy. It speaks to only microsurgical therapy, and that's important to remember, because I think a lot of people, when they see AVMs, their first thought is that if it's a high surgical grade, it must be at a higher risk to injure the patient. That's not necessarily true, and it has not borne out in one of these studies that I've been mentioning earlier. So here are nice images that, kind of talking about some of the things I mentioned. Here's a non-contrast head CT, and again, you can see these chunky calcifications here in the frontal lobe on the right-hand side. And here's your AVM. This is a big venous varix here. You can see it on T2. You see large, what we call phloboids. Obviously, it's difficult to differentiate that which is venous, that which is arterial. Certainly, when this large is going to be venous. This is to cut slightly lower down. And then these are the corresponding images from the catheter angiogram, where you can see there's this large middle cerebral branch that comes up and dives into this large venous varix. You can see here on the AP projection. And then see here on the vertebral injection now are these small little lace-like arteries that kind of look almost like they should be part of the AVM. What those actually are just PO collateral supplying the AVM, in and around the AVM, because the traditional blood supply is being sumped into that AV shunt. You presented with an intraparenchymal hemorrhage, kind of has that classic look for hypertensive bleeding for this younger patient. So CTA was done, and there was a suggestion that there might be an AVM, so we did a catheter angiogram. And what you can see here is this small tangle of vessels here. Again, it's kind of centered in the perisylvian region, kind of insular aspect. The other reason I'm showing this is because there's supply here from the middle meningeal artery. This is an AP projection from a catheter angiogram, and this middle meningeal artery running up through the foramen spinosum, and you can see here there's a contribution to the AVM itself. Another compilation of images, another basal ganglia type hemorrhage, or perisylvian, and what you can see here is that the AVM itself has been split. So here's a parasagittal projection showing this wedge-like portion of the AVMitis. Here's the hemorrhage, and then there's this portion out here out laterally, and this is being displayed here. You can see there's a thalamus perforator that comes up, and the portion of the AVM, and then there's the superficial portion of the AVM. And the Watson-Young supplementary score, patients are actually given AVMs are not hemorrhaged as opposed to hemorrhage, because hemorrhage, though obviously patients don't do as well once a blood surgical standpoint that actually can be helpful to the surgeon for one of two reasons. One, the hemorrhage can help actually dissect away a lot of the tissues, can make things easier then to remove, but also it absorbs a lot of the morbidity related to the open craniotomy that is subsequent or is required for any sort of surgical intervention. As of AVMs, one here in the pulvinar, the back of the lips. Here you can see this enlarged PCA branch or this kind of very long mesencephalic branch feeding this AVM here. This is what it looks like on catheter angio. Kind of a busy slide, but I think this is a patient that ultimately went on to gamma knife. Bold imaging. These are images taken from an fMRI, and what they're just trying to show is mapping certain portions of the brain during certain types of activities, whether it's finger tapping, moving your foot, or things like that, to try to locate both language and also motor activity relative to this patient. This is a 3D rotational image taken from a catheter angiogram. You can see here off of this anterior inferior cerebellar branch, there's a little bump here, and this is a flow-related aneurysm. We noted that flow-related aneurysms or intranidal aneurysms range quite a bit. Sometimes they can be as low as 5% of AVMs. Some series have them as high as 50%. It should be noted that posterior fossa AVMs in general more often will have flow-related aneurysms. We don't know exactly why that is, but they also more often will present with subarachnoid hemorrhage. And we don't exactly know where AVMs bleed from. Definitively, is it vein? Is it the nidus? Is it the artery itself or the brain parenchyma that bleeds? We don't really know. But we do know that when you see a subarachnoid hemorrhage in the setting of an AVM as the primary presenter, it's often the aneurysm that's the problem. We have good evidence to suggest that by treating just that hemorrhagic site, you actually return a patient's natural history risk back to that kind of 2 to 4% annual risk of hemorrhage as opposed to the higher 8 to 10% that we see in the first year after hemorrhage. Picture is just showing intervention that we've done here. This is a very, very complex left kind of auricular or Sylvian AVM, and you can't see this here, but there are a series of coils and blue shots in here to reduce the AV shunt, and this is in preparation for surgical resection. And so not least, here's small temporal AVM that we actually were able to cure using a single injection of absolute ethanol. Probably enough on AVMs. Moving on, so it's a 44-year-old with seizures. And I didn't get into that. No. The one I wanted to mention here that I didn't talk about, but we should. This patient suffers from Osler-Weber-Rondeau or HHT, hereditary hemorrhagic telangiectasias syndrome, and this is a well-defined genetic syndrome. It's manifest with all kinds of mucocutaneous telangiectatic lesions. You can see that in their mouth or in their nose. They typically have AVMs in the brain or the liver or the lungs. They can get pulmonary AVMs as well, obviously. And this important subset of kind of the AVM population and informative to us as researchers because this is the only animal model that we have for AVM research at this time is the HHT model. We don't have a good animal model for kind of more traditional sporadic AVMs. So a lot of the kind of basic science you will hear about patient to AVM stems from understanding or from study of this disorder in particular. Okay. 4-year-old with seizures and a chronic unilateral headache. This is a non-contrast head CT. You can see here there's some high-density structures, kind of globular structures here in the posterior temporal lobe. This is the corresponding flare image on an MR, coronal projection. You can see these blobby kind of flow-void type structures here. And this is a T2-weighted axial image. Again, doing these same things. Here it is in a parasagittal image. And so this is enough to suggest that this patient needs some sort of catheter angiogram when you see these types of normal vessels in and along the brain surface. So, the patient has a dural arteriovenous fistula, or AVF, and we collected catheter angiograms of vessels within the dura or the scalp. And so this is the occipital artery and lateral projection. You can see it here running up and feeding the scalp, but you can see here they're shunting into a collection or vessels that all coalesce here at the back of the transverse sinus. And then you can see here that it's shunting up into a ballooned out cortical vein. That same projection, lateral projection, taken from a more distal aspect of the external carotid artery, and here's enlarged branches of the middle meningeal artery running back and coalescing in this central area and then shunting into these cortical veins. The corresponding AT projections, that middle meningeal artery here on AT projection, and here's that occipital artery coming up and getting it on the back side. And so we treat almost all of these patients through the blood vessels, through a number of different types of materials. Some of them are permanent lipid embolic agents, like this black stuff here. This is what we call onyx. This is a vinyl polymer, and it flows like toothpaste through blood vessels, but it kind of casts them, and it prevents arteries from seeing the veins. And you can see the same projection on the AP here. You can see we filled all this stuff. Let's see, there's no more shunting. So fistulas, moving down the scale of valence. If aneurysms were common, AVMs are rare. Dural AVS are just a subset of AVMs. They're very uncommon, actually. We see a disproportionate number here at UCSF, so we have a lot of experience with them, but it's not something that you're going to see routinely. They are common in women and men, and they present a little later in life, kind of like aneurysms do. In terms of their natural history, they really just spontaneously involute some sort of a traumatic history or a hypercoagulable history, meaning like DVT, or pulmonary embolism. Those can be risk factors for the formation of dural fistulas, but we still don't actually know what causes these. There is no good kind of animal model in terms of how these form, so we're very limited in terms of our understanding of them. The thing to remember about dural fistulas is, from an imaging standpoint, you present a hemorrhage, that's a good indication that you may need to do some sort of angiographic sequence, whether it's a CA or an MRA, or hopefully even a catheter management. Another thing you can look at is the arterial foramina. So I mentioned the foramen spinosum and the vessels that that, i.e. the middle meningeal artery. So if there's been long-standing shunting or a need for more flow through a vessel that runs through a skull-based foramina, or any foramina for that matter, that foramina oftentimes will accommodate that by increasing in size. And so you can look at the bone windows on a CT sometimes and see these enlarged channels, whether it's through the mastoid bone, obviously through this bone, or other locations. Fistulas are hard to identify. They're not like aneurysms or AVMs where they can sit in a space where they're easily found. They actually, kind of run in that potential space in the dura itself. And so oftentimes what we'll see on a lot of reports is we kind of quote too many vessels, unquote. That's a fine description of them. I think it's very hard to say definitively if something's a dural fistula, if it's something as an artery versus a vein. I think it's fine to just say that there are too many vessels and that this patient needs a catheter angiogram or some other type of angiographic sequence to rule out this disorder. Locations again are going to be the transverse sinus and sigmoid sinus junction and the cavernous sinus. So here are just some classification systems. Again, I think classifications are important if you're going to read papers or you're going to do research, but ultimately the big thing to remember is that as parasitize the cortical venous drainage of the brain substance, that's the pinch you need to worry about. So this is the Cavernous classification. This is probably the one most commonly used. It's a very busy slide, but suffice to say, in the early types, or the types that we consider benign, essentially what there is just anterograde flow out the vein back to the heart. And basically the bleed risk on those patients is nil. Patients more often present with things like pulsable tinnitus, or hearing the pulse in their head, which can be very bothersome in itself and is not benign either. Nonetheless, it is not a risk for what we consider stroke. Only when they start using those cortical veins that we consider stroke to be high. You see here the corresponding percentages as that cortical venous drainage is incorporated. This sort of classification is just a simplification of the Cavernous classification. So I mentioned low-risk dural fistulas. They present obviously pulsal tinnitus, pain, sometimes headache. The high-risk ones, they'll present as hemorrhage. You can actually get venous congestion of the vein from which the cortical veins are supposed to drain, and that can manifest in all types of things, including personality changes, seizures, and other types of things. These are just some pictures showing, low-risk drainage returning back to the heart here. Here's the shunt coming up, and then it returns down to the telangiectasia vein. With this, you can see there are all these congested, we call it a pseudo-fluidic cataract type picture of these veins that have nowhere else to go. Last but not least, in space, you should always remember that dural fistulas or venous congestion does not necessarily have to originate within the brain itself, or for things that in the brain itself to actually affect other parts of the body. This is a sagittal T2-weighted MR, and you can see all of this high signal here within the brainstem and then the upper cervical cord. This is a flare type image here showing that same information. And here there's some asymmetrical edema here and enhancement within the medulla, the lateral medullary portion. And we've seen patients brought to our center with the presumption that this person has like a glioma. They've actually had biopsies of these lesions. And what the patient actually turned out to have was a dural fistula. And so here it is, the occipital artery coming up, and it has a branch that comes up and directly connects cortical vein. Excuse me, guys. This is the corresponding intraop CT that I did, just showing where exactly that shunts in. And this is like down here toward the base of the sigmoid sinus. And then this is showing, this craniotomy here. This was for a biopsy, actually. This wasn't for any sort of surgical procedure. This is the onyx material that we placed there and disconnected that. And that woman went home, actually, a few days later and did much, much better. Finding out some of the vascular issues. This is a gradient-weighted sequence. You see here there's a lot of susceptibility artifacts central within the brainstem. This is the corresponding kind of T21. You can see this kind of fluffy type T1 signal here within the central portion again of the medulla. It is on a GAD-enhanced space. Comparable type case, again, that kind of what we consider popcorn type. So that's T1 high signal here in the frontal lobe, just in the subcortex, and here's that blooming that you see on the gradient sequence. It is on flare. Just showing again that high T1 signal here with kind of some and ring around it. And this is a cavernous malformation. So these are, again, now a little more common. We'll back up to a prevalence of about almost 1% in the population, equally affecting men and women. It's primarily within the 5th decade or the 6th decade, so patients in the 50s are going to be solitary, and their bleed rate is on par with a lot of types of small aneurysms. If multiple, your ICH rate will go up a little bit, and most of these again are manifest as seizure as opposed to any other type of thing. So I mentioned CT is again the workhorse. That's where most of our imaging starts. They have that kind of popcorn calcification, or kind of like bubbly appearance. Percent obviously will calcify. Obviously, as your kind of go-to, you get that mixed T1 signal, which you can see on some of those images. You will see that hemocentral ring on T2. At variable, sizes. Obviously, some of them can be very punctate and small, but others can be much larger. Gradient is a great way to try to find these. Obviously, susceptibility artifact is a great way to locate them. Obviously, this Zambrisky stage is a way to kind of help identify how old blood products are. After angiogram has really no purpose here. We consider these typically a cult, and they're cult because you don't see them on a catheter angiogram. So if you do have one of these, you don't necessarily need to do a full-on BSA. The real exotic stuff, this is a couple with high output cardiac dysfunction. If you're interested in these kind of rare types of disorders, this patient has a malformed kind of vein of Galen. So this is the falcian sinus here. This is kind of an embryonic structure that did not regress. You can see this is an image from an MRA, showing all these vessels coalescing on this big lymphy and varix here. And this patient has a vein of Galen malformation. Again, very rare, but very debilitating, particularly when patients present with multi-organ failure early in life. This is a catheter angiogram showing multiple inputs into this large and shunt. Here it is this is the right internal actually the right vertebral. This is the left internal. Here, all of these kind of coalescing on these lateral or marginal aspects of the recipient barracks. And so we can go up and treat these. People who are 30 hours old, we'll look at their umbilical arteries actually because their vessels are so small. Almost done. You can see here what we're actually doing is we're placing some coils in here. And so the idea in these very, very sick kids is not much to try to cure them. All we're really trying to do is temporize them so that their brain can mature and it can be treated more definitively at a later time point. But ultimately, though their presenting issues are often types of kidney, liver, or even cardiac failure, the issue remains shunt because of that physiology is overriding the normal ability of the heart to pump out enough blood to provide nutrient supply to all those other organs. So again, here's venous malformations, very uncommon, in 1% of all vascular malformations, but a percentage of the pediatric population, again, because we just don't see that many at that age. They're more common in men than women, or I'd say boys and girls. And true of a lot of pediatric vascular things, whether it's aneurysms or AVMs as well, at that age. The natural history, as I mentioned, neonates, congestive heart failure is kind of a big thing that they manifest as infants. So that's, actually less than 30 days. They prevent syphilis because of the of the aqueducts or venous hypertension, which limits the ability of CSF absorption, and they have developmental delay. But they often present in adolescence as seizures and other types of forms of developmental delay. Obviously, we can see some of these things prenatally you can see a dilated midline structure, as we were talking about. They can be hydropic intermittent, and you can get congestive heart failure intramural as well, though it typically happens after the baby is born. There's a role for MRI here, but we don't obviously do that as often. Obviously, you can do transcranial ultrasound through the Fontanelle. Very effective at identifying these issues. CT can be helpful in terms of looking at for hemorrhage or calcifications. And then MRI is probably a better thing to look at encephalomalacia or other types of areas of the injuries. So a lot of these patients will have significant brain injury, and thus, if we feel that the damage is such that the patient is not going to probably have a meaningful survival, oftentimes we'll consult with the family as such. We only use catheter angiogram when we're going to treat. It is not a diagnostic tool in this setting. We don't need it to kind of make that diagnosis, but we do need it for treatment. So there's no need to rush these patients for catheter angiogram unless you have an intention of actually doing something. As corresponding images, here's a grayscale image in the sagittal projection transfontanelle. You see the big recipient barracks, and you see all these tiny little vessels coming through here. This is it with a Doppler, just showing all these vessels again, coalescing onto that barracks. And this is our Doppler image showing that same information. Galen just showing how large these shunts can be. These can take up a significant portion of the intracranial content, and you can see how debilitating these can be for a young child. So here's another image. You see this tiny kind of Medusa head type appearance of some what looks like vascular structures coalescing down toward the ependema of the lateral ventricle there on the left side. What we're trying to show there. What we're showing here is, again, here's a high-density structure here in kind of the temporal lobe on the right side. This is on a CT, different patient. Here's the corresponding CTA, and what this looks like, again, this is that Medusa head type appearance. And sagittal projection, or excuse me, coronal projection, just showing all of these veins kind of coalescing down toward the ependema of the ventricle. And this is a developmental venous anomaly. This is something that we've seen oftentimes in association with cavernous malformations. This is a benign etiology in and of itself. This is not something that needs to be treated surgically or endovascularly in any way. They can be monitored. They have no significant bleed risk that we're aware of, and people who have tried to treat these ultimately cause more problems than anything else. These drain normal brain so they're perfectly okay. So when you do see them, they're fun to point out because sometimes they can be associated with cavernous malformations, which we discussed earlier. But ultimately, they're not something, not pathology, so to speak. They're in here only because people can kind of lump them in with cavernous. From an imaging standpoint, I mentioned the medusa head picture, often adjacent to the ventricles because they drain down and coalesce toward the deep system. And MR, again, is helpful because they can be associated with a cavernous malformation. This is kind of a cousin to the DVA. This is kind of that kind of paintbrush look appearance, so this kind of brushy look here. This is an SWI image. And then here's another one showing some signal here in kind of the central portions of the midbrain. Here is a little edema here next to this black duct. This is that T2-weighted corresponding image. Here's this kind of, again, paintbrush appearance, that same patient on SWI. And here it is on CAD enhancement. So again, you see this almost kind of hazy look to it, lace-like appearance to it. And what this is just a telangiectasia. And again, this is a benign malformation. It happens in a lot of patients. It affects patients kind of equally in terms of their sexes. But again, certain locations within the brainstem and other people can associate it with certain types of neurologic findings, but ultimately it does not need to be treated per se. It does not carry a hemorrhagic risk as some of the other things I mentioned. Here's what it looks like on CT or on imaging. We can see occasional calcifications, but it's in nature very small. It does show up in the brainstem and the local matter. On MR, you can obviously see intensity and engineering, and then last but not least, you can see that kind of brush-like appearance with asking to do something. I'm almost done. I got 2 slides left. All right, guys, this is the last one, I promise. This is a sagittal image showing again multiple flow voids pulling down toward the ependema, the lateral ventricle. This is responding axial TT-weighted image. Showing that same information, you can see these structures here, but you can also see there's kind of an asymmetry in terms of the gyration pattern here, and then the contralateral side. You kind of see this kind of like very bright appearance to the text here on this patient, and then a post-gag coronal T1-weighted image. Here it is axial plane. This patient has Sturge-Weber, so this is essentially a abnormality of the development of the cortical veins within patients. It's a malformation disorder. Patients more often present with seizures. They classically will have a capillary malformation or port-wine stain in the V1 distribution in their face and have a genetic association with the VASA1 disorders, but it's relatively uncommon. On M, you'll see cortical calcifications and obviously cerebral hemispheric atrophy. More often than not, it's unilateral. That leptomeningeal enhancement, that very kind of bright kind of appearance we were just talking about, that represents angiomatosis, and so that's just vessels trying to supply blood to the brain, which do not have its system developed appropriately. And then what you'll see in terms of on a capital angiogram, that comes to that is you'll see this absence of cortical veins, but the deep venous system is present, and that's why you see those enlarged vessels trimmed down to the ventricle. This is just a workflow chart kind of talking about how we work up ICH. Suffice to say, when you have an isolated inflammable hemorrhage, if they're greater than 40 years, have a treated anticoagulation, coagulopathy, or in the brainstem or deep gray matter, this is kind of classic for your hypertensive bleeds. You can go directly treatment. You can go to GAD enhanced or contrast MR, but you really don't need to go into capillary angiography. You can't see my slide here. It's going to move away. So for other patients, so these are obviously less than 40 or don't have these types of things, we always will do a CAT scan with an angiogram component or an MRA. If there's no evidence of venous thrombosis, we'll move into the DSA category. We're trying to identify whether it's vascular that needs treatment, and that's pretty much what we've been talking about for most of the morning. It's non-vascular, i.e. like a tumor or some other type of thing that requires medical therapy. Then sometimes we'll still do a follow-up study 4 to 6 weeks later. Oh, I'm sorry, last one. This is for intraventricular hemorrhage plus minus subarachnoid hemorrhage. Just again showing the workflow of how we deal with things in terms of working patients. So a few questions. I got, I guess, 8 o'clock, but we still are here. I hope you guys were able to all that. I did supply some questions to Lori. I don't know if she'll be able to get those to you guys, but I appreciate your time, and I hope to see you all in person sometime soon.